All right, good morning, everyone. My name is Whitney Isola. I am a co-founder for OncoPower, which is a digital health platform that builds tools for both patients and providers specific to the oncology market. Definitely join our platform today and see what types of tools and resources are there that are available to you. We have with us today Dr. Gershenhorn. He is the previous director of the lung cancer program at CTCA, Cancer Treatment Centers of America, and is currently a practicing hematologist oncologist at the Advocate Aurora Healthcare System at Good Samaritan Hospital in Downers Grove, Illinois. So he's here today with us to answer all of your lung cancer related questions and to really, walk us through what being a patient and experiencing that, that treatment course looks like. So Dr. Gershenhorn, welcome.
Thank you. Thank you for having me.
Yeah, so I'm going to keep an eye on some of the questions as they come through. It looks like the first few that came in were related to breast cancer and CDK46 inhibitors, again, related to breast cancer. So why don't you just start us off by talking a little bit about, your experience, what got you into specializing in lung cancer and, what you see most often for your patient care?
So actually, I completed my fellowship about 15 years ago. And for the first few years, I was doing a little bit of everything. So as a trained hematologist and oncologist, you do all cancer types, and you do hematology, which are blood diseases and blood cancers. So for a few years, I did that. And then I moved on to CTCA, which I spent the next 10 years of my career in Chicago. And there's when I really focused my expertise on lung cancer. And I directed our lung program for the past 7 years there. And we developed a multidisciplinary team. And in lung cancer, and a lot of cancers, but specifically in lung, you really need a lot of resources around an oncologist to do the best you can for a cancer patient. And that's from diagnosis. When someone's got say, for example, has a CAT scan that showed a lump or a spot or a mass, there's a lot of different terms, nodule, to the workup, which a lot of times will include a pulmonologist and specifically trained pulmonologists who are expert at getting to biopsy sites. They're called interventional pulmonologists. Thoracic surgeons, which are surgeons that specialize in the chest cavity. Most do heart and lung surgeries. They're called cardiothoracic surgeons, or just thoracic surgeons, which super specialize just in the lungs and not the heart. And radiation oncologists, which are doctors, and we can get into all the specifics if there's any questions on these things, but radiation oncologists who specialize in radiation treatments toward cancers. And then there's also medical oncologists and interventional radiologists. And a medical oncologist, such as myself, who's trained in general medicine and then subspecialty trained in oncology, really focuses on from the beginning, diagnosis, all the way to the entire cancer journey, whether it's help with the staging workup, whether it's figuring out how to get a biopsy, whether it's getting specific consultants from other subspecialists, and then, of course, the drugs. Medical oncologists prescribe the drugs. They don't do surgery. They don't do the radiation part of it, but they prescribe the drugs, whether it's pills, IV drugs, whether they're chemo, targeted treatments, immune treatments, and we can get into all that if there's questions, or we can talk about that also in more detail if anyone would like. But that's kind of the medical oncologist role and in the overall cancer journey. And I built a program at CTCA where we went from diagnosis all the way through all the treatment options and research.
Fantastic. So what excites you most right now in terms of the treatment options that are available to oncologists? And where do you see, the options going in terms of some of the R&D that's in that space?
So For decades, it was chemo and new chemo drugs. And chemotherapy is just a generic term for cancer-fighting medicines or chemicals, usually as an IV, goes in the vein. And then over the last 10 years, there's been two huge advances in cancer care. One being targeted drugs, which are pills. A lot of times pills, sometimes they're IV, but they're targeted. So they're looking for unique features in a cancer that made it different, that made it tweaked. The way I think of it is, if you're talking about like a bumper car track with a lot of cars running around and all of them are kind of going at a fairly safe speed, bumping into each other without causing any injury, and you take one of the engines out of one of the cars, and then you put in a much more souped up, faster engine that now runs around the track really fast and doesn't pay attention to the other cars and bumps them out of the road. Now, those engines that were put into that car that made it behave poorly, those are, we have target drugs. We have ways to first find that engine, name that engine, and then we have ways to, from pharmaceutical companies producing drugs that target that engine and kind of shut them off, almost like a key to shut the engine down. So that's a whole class of treatments that we didn't have in lung cancer maybe 15 years ago. And now there's, and especially in lung, I would say lung cancer as opposed to other cancers really led the way in this. But in lung cancer now we have dozens of drugs that target multiple different engines. And some are super active, have, they're pills that you take once a day, and they're very well tolerated. They all have their own unique set of side effects, but they're very well tolerated. And they can be very effective with shrinkage rates, meaning when a CAT scan or a PET scan shows a lung mass or a mass on the liver, say, for example, of a spreading lung cancer, where it just shrinks way down, which tells you that you killed off a large percentage of those cells. So they're very active, targeted drugs. And the way to look for those targeted drugs is to look for those engines. So that's a whole class of treatments that 15 years ago, we weren't really even speaking about in lung cancer. And now we have probably 25 plus drugs to target some of these engines. Now, not every person with cancer, lung cancer especially, has an engine that you can target, but some do, and looking for them could completely change the landscape of options for them. Then the other category, so there's the chemo category, there's the target pills or the target drugs category, which are predominantly their pills. And then there's the other category, which I think is, to me, actually the most promising. It's the immune medicine category. And the immune medicines are really unique because what they'll do is they're almost all IV, at least at this point. And they'll try to teach your immune system how to understand and see the cancer cells as disease damaged cells in the body and just remove them. Now, we think of our immune system as our army inside our body to fight off, like COVID, for example. That's huge these days in the news, or just any infection someone might suffer from. But the immune system does a lot more, and it's your inside power, it's your inside army, your police force to keep your body healthy. And if you could exploit it to go after the cancer cells, now you've got a really effective treatment. So, and this has been known for 40 plus years, and immune drugs, interleukins and interferons were tried for years, but they were revving up the immune system, but they weren't necessarily telling the immune system what to do, what to go after. But over the last 5 to 7 years, actually, not even more than that, there's been a class of agents called checkpoint inhibitors. And the class in checkpoint inhibitors are the PD-1 or the PD-L1 class. And those drugs have revolutionized the treatment options and the prognosis for people with lung cancer. Now, up until very recently, it was only for the 4th stage cancers, meaning the lung cancers that had already spread outside the lung to other areas of the body. And they're used as the first treatment, sometimes with chemo, sometimes without chemo. Now they're starting to make headway into, and just as of last week, literally about a week ago, one of the checkpoint inhibitors, the PD-1s, got approval in the second and third stages of lung cancer. So before it became metastatic, before it spread. Metastatic is the word for it spreads outside of where it started. So the three main treatment approaches, one of them is kind of still a standard and frequently used, which is the chemo drugs, and there's a lot of them too. Then the target drugs, which are newer and much smarter type therapies where you're really understanding what's engine active in cancer and taking a pill usually to shut that engine off. And then the third category is the immune drugs, which are ways to exploit the immune system's potency and fighting off anything that's making your body ill, and using those drugs to tell your immune system how to just shut the cancer down. So these three categories are our armamentarium as a medical oncologist, and the second and third one being the ones that are much newer and much more promising.
Fascinating. And we really appreciate you walking us through that. Do you mind kind of, talking through the staging for cancer and what the survivability is for later stage lung cancers?
Sure. So the staging, like pretty much every cancer goes from a 1 to a 4, and it's the TNM staging system, AJCC TNM. T stands for the tumor size. N, as in Nancy, stands for the nodes, the lymph nodes that would be around the cancer. And then M in the TNM, M stands for the metastasis, whether or not the cancer metastasized to another organ or somewhere distant, put it that way. And that TNM, every person that gets diagnosed with cancer has a stage based on their TN and M. And those three categories together define the person's stage. And the stage will go from a 1 to a 4. So you can ask your oncologist, what's my stage? And they may say, oh, it's a T2N0, M0, which is a stage blank. And it would be a stage 1 to 4. And every cancer is a little different. Sometimes certain ones are risk stratified, like in stage, like for example, in lung cancer in the third stage, you might be a 3A, 3B, 3C. So there's a lot of nuance to the staging, but I would say in general, it's a 1 to 4. And the treatment approaches for the 1 and 2s, surgery. If someone's not a surgical candidate, then sometimes we'll do high dose radiation at the cancer. But for the 1s especially, we don't usually do anything else after either the surgery or the radiation. For the 2s, after the surgery, we usually will do chemo. And there's now emerging evidence that there's a target called EGFR. If someone has that, you can take a pill to shut down that target in the 2s. And even an immune drug that just got approval last week for stage 2s. For the third stage, again, that's when we go from a 1 to a 4, we go from very small and isolated in the lung to 4 being spreading outside the lung to another organ or another area of the body. So a third stage is when it gets not far enough to go to another organ, but far enough to get to the lymph nodes that are in the middle of the chest. We call that the mediastinum, the location in the chest where the lymph nodes can, where there's lots of there's lymph nodes everywhere in your body, but this is just a location on lung cancer where if it gets to the cancer cells, get into that lymph node region, we call it a 3 stage. And most of the time, I would say 95+% of the time when it's a third stage, we don't do surgery anymore. Surgery has not been found to be super helpful in the third stage. So the approach for the third stage is you give radiation. The radiation is external. It's a machine that pushes energy in to your body. We do the radiation with chemo together, and it usually goes on for about 6 weeks. And the radiation's every day, little dose each day of energy. And the chemo, depending on what regimen, could be once a week, could be once every 3 weeks. And that goes on usually for a 6-week period. And after that's done, we do an immune medicine. And the immune medicine's given for a year. Usually, depending on which drug's chosen. And for third stage, we usually do it every 2 weeks for a year. And that's in the vein. For the fourth stage is when it spreads either outside the lung to the other lung or to another organ. And lung cancers will typically spread in very unique patterns to specific organs only. And if it spreads to another organ, then surgery is really not an option. Radiation we sometimes do, but that's more for symptom relief. It's not for a cure. It's for control of symptoms. And the treatments revolve around some of the drugs we talked about, like chemo drugs, target drugs, immune drugs, depending on some of the unique features of that person's cancer. So you got to do testing to determine what features are active and what features are unique in the cancer so that you could tailor the best treatment for them. Now, you also asked about prognosis based on staging, which is the whole point of the staging system is that it's to determine what's the best treatment and then what's the prognosis based on the stage. And we think of the 1, 2, and the 3 stages as curative treatment. So the goal is to complete the treatment and hopefully follow the person closely afterwards, whether it's every 3 months or sometimes shorter, sometimes longer. But we follow them after we're done with the treatment in hopes that this never comes back. And that's the 1, 2, and the 3 stage. The 4th stage, since it's already spread outside the area, it's much harder to get long-term control. It can happen. I don't want to crush hope that that's not possible, because it is possible. But it's harder. It's harder when the cells spread and move and run through the bloodstream and go to other organs. And the survival rate when you're in a 1 stage or a 2 stage could be pretty high. 5 years, some people 70, 80%, even upwards. When it gets to the 3rd stage, it's a little bit lower. And when it gets to the 4th stage, it's lower than that. And the 4th stage, the 5-year survival rates are usually quoted. And this is tricky because it's usually quoted in the 15% range. But some people do excellent, and a lot of people don't. Now, the people who do excellent, it's because the treatment that you gave them was effective, whether it was the target drugs, whether it was the immune drugs, whether they just were a unique, really active chemotherapy responder. But the response to the treatment you give and how they tolerate the treatment you give has a huge impact on the prognosis and how things are going to go. So I sometimes shy away, well, I'll frequently shy away from quoting statistics until you see how that individual person's journey goes for them. Sometimes it goes, unfortunately, worse than expected. Sometimes it goes much better than expected. And as an oncologist, when you sit there with a white coat and you tell a patient, this is your average survival rate with the drugs, this is your average survival with that, it's very difficult information to swallow. It's frequently not accurate because you don't know if that's going to be a responding person or not. You don't know how they're going to tolerate it. And it can be, it can set the tone in the wrong direction. Now, as you battle the cancer with them and you start treatment, it becomes pretty clear. Are they losing weight? Is the treatment ineffective? So when you get to a scan after a couple of months of a treatment, is it not working? Mm-hmm. And then that would determine, okay, this isn't going to go as well, and we should have conversations in that direction. Or do they have an EGFR mutation, for example, which is one of these common target engines we find. And a year from then, we're on a pill. The person's living their life like they were living their life before cancer. So very hard to speculate at the beginning. And sometimes I find it not palatable unless the person wants. But you can give general ideas, but not to get into too much detail from the beginning because you really don't know how it's going to go. Sometimes family members request more information than the actual patient. I find that a lot. Family member will ask a very targeted question about prognosis. So then I'll look at the patient and I'll say, tell me how much information you want right now. Tell me what you want to hear. Do you want me to answer that question? And sometimes, a lot of times actually, the patient will say, I'm not interested in that right now. we can do, I get a sense of what's happening. I understand I'm in a big battle here, and understand this is life threatening, but I don't really want the statistic. And actually, that's actually quite common. And then I can provide the information to a family member, but maybe not to the patient at that point. So prognosis is a little bit tricky, and it's easy just to spit out a number, but it's actually, I think, me personally as an oncologist, it's a heavy piece of information to provide. And when you're an oncologist with a white coat saying this, the patients think that, that's the answer, that's definitive, that's what's going to happen. Let me put my calendar date for this. And it's not true. So I'm just very cautious about that.
Yeah. Yeah. No, I can see how you take that role with a lot of gravity. We do have a question that came in. We have from Ram. We have seen a number of treatment options approved for non-small cell lung cancer, but we don't seem to see the same look with small cell lung cancer. What are your thoughts?
That's a very good question. So the world of these targeted drugs, again, there's dozens of them, has really been reserved for the non-small cell type. Now, the non-small cell type encompasses about 85% of lung cancer diagnoses. So this is the vast majority. And a lot of these target drugs seem to be more commonly seen in non-smokers or in people who smoked and quit a long time ago, and in a specific subtype of the non-small cell called the adenocarcinoma. So when we say non-small cell, let's go backwards a little bit because there's a good question, and I just want to make sure we're all on the same page here. So there's two types of lung cancer. There's small cell, and then there's non-small cell. And that's how we separated lung cancer for decades. Small cell is almost 100%, not quite, but almost 100% of the time seen in a heavy smoker, frequently active smokers with COPD, which is lung disease from smoking. And unfortunately, the cigarettes probably over decades have caused multiple cancer driven mutations in cells that make them hard to target with an individual pill to target the engine. Now, that being said, the immune drugs, which is the other category we talked about, can be, I've seen remarkable results in the immune drugs in some small cell lung cancer patients. I've had patients, and this isn't typical, but I've had patients with small cell lung cancer with spreading in the brain, spreading in the liver, whose disease disappeared with these immune drugs, which never would have happened before. So in small cell, it's predominantly a disease of smokers. And a lot of times when you start looking for these engines, you find many, many engines as a result of a heavy smoking history. And we don't have good targets to shut down when there's so many different engines. For the non-small cell type, again, which is 85%, and specifically the adenocarcinomas are the most common of the non-small cell types. Them, and especially if you look for the people who didn't smoke a lot or never smoked, which can compromise 10% of lung cancer diagnosis. In some centers more, some centers a little bit less. That's where you find these engines, and you find lots of different targets. Like, for example, EGFR is the target we've known about for the longest period of time, and it's been probably 15 years plus since we've known it. And there's drugs that shut down that EGFR engine. Now, they can shut the engine down for months. Sometimes they shut it down for years. And the drugs now we use are very well tolerated and very effective. There's other engines like ALK, ROS1, BRAF. Think of these as like Ford F-150, Ford C-Max, Ford Explorer. Think of these, they're basically the name of an engine that's active in a cell. And frequently the cell might have few. Sometimes it only has one, sometimes it has 20. But some of these engines we find, like the ones I just mentioned, there's other ones. There's in lung cancer now, there's, especially again in the non-small cell type, there's RET, R-E-T, there's MET, exon 14, there's KRAS, which is one that we've known about for a long time, but now we have a drug for a very specific type of KRAS. So if you enrich for the non-small cells and the adenos that never smoked, you see it frequently. But if you look just on all non-small cell adenos, you do find them. And why do you not see them in the small cells? A little less clear, but the biology of how that cancer forms is probably a lot more complicated and not as pure as one target was tweaked and this is the engine. Now we have a pill to shut it down. So unfortunately for a small cell, besides the immune medicines, we still haven't made a lot of headway in the target category, and haven't made a ton of headway in the chemo category either. For the non-small cells, we've made a lot of headway. And now, for example, every person that comes in with a non-small cell lung cancer, again, especially the adenocarcinomas, which is the most common type, we want those engine tests, which we call NGS, or next genome sequencing, NGS, or some doctors will call it genomic testing, genetic testing, a lot of words, but it's basically to look for the target engines that are active in that cell. And that's a very fancy test that needs to be done. It takes a couple of weeks, depending on where you send it out, anywhere from 1 to 2 weeks. And you usually do it from the actual cancer biopsy. You could do it from the blood. That's a new technology where you can find it in the bloodstream, which again is a whole other conversation. But you do the genomic testing to look for those engines. And then if you find one, now you got a target to go after. And again, that's much more common in the non-small cell type.
That's very helpful. Thank you. We did have a question come through on the OncoPower platform that was more related to nutrition. I do want to let everyone that's watching know that we have a registered dietitian on the platform who answers questions that pertain to cancer and nutrition care. But we would love your thoughts as well, Dr. Gershenhorn. So the question was regarding stage 4 lung cancer and vitamin D supplementation and the benefits of that. Do you routinely recommend supplements for your patients?
So this is a good question and a little bit outside of my realm, but I could kind of tread lightly into that world. So vitamin D deficiencies, when you check the overall population of the cancer population, you see it fairly frequently. It's somewhat unclear if you just supplement vitamin D, does that help, and how much can that help? I do defer a lot of this to our dietitian that I work with. I would say in a broader scheme, just the complementary world to cancer is gigantic. It shouldn't be brushed off by a conventional doctor or conventional oncologist. Patients are very interested in it. There's a lot on the internet about natural supplements, vitamin supplements, specific diets. For example, a lot of patients will ask about some of these diets where they eliminate sugar or they'll juice as ways to help fight the cancer, because people want to do something. They want to take a drug and they want to see an oncologist. They want to get the conventional approaches, but they want to be proactive too. And there's ways for them to be proactive, no question. But a lot of the specifics on whether it's vitamin D or whether it's any other supplement or any natural treatment. The CBD oils has become a huge part of not a medical oncologist training, but a huge part of the patient's interest on what they can do, what they heard from a friend, what they read on the internet, as far as using the CBD oils or the whole world of medical marijuana, which, as we all know, went from being illegal to being available for medical use in certain states to now recreational use, and depending on your state, access. So that whole world has changed dramatically. There's not a lot of research, and it definitely has activity in certain symptoms. People who have a lot of nausea and have poor appetite. they may benefit, but it definitely has value in symptom management. As far as, is it an effective treatment for cancer, or can it help fight cancer, is a whole other question that's really not proven in the medical literature, but something that patients commonly ask about. So vitamin D is one thing, but it's almost a broader question about complementary treatments to cancer, which I would defer a lot of that to experts in, and there's a lot out there that nutritionists who focus on cancer nutrition. A lot of the cancers that I'm sorry.
Oh, sorry, I was agreeing. I said absolutely.
Oh yeah. So you know, a lot of the intestinal tract cancers that I treat too, for example, like a pancreas cancer or stomach cancers, colon cancers, you know, it affects your digestion and your whole system. So there's a lot to that. Some of the immune medicines now, there's a lot of interesting studies on the gut microbiome, meaning the bacteria that lie in your intestinal tract that help break down food for you, whether that has an impact on immune drugs. So it's a whole world that we should never discredit, just because we're not well trained as conventional medical oncologists in natural treatments, for example. It doesn't mean it's not an important part of a treatment for a patient, but I would make sure that whoever you're getting advice from, that's a very reputable source. And some big cancer centers do have fairly good nutrition programs, fairly good naturopathic programs. Sometimes there's websites where run by these cancer centers where you can really look into this and make sure you're making a right decision that's not going to interfere with your treatment, but that would hopefully make your treatment better tolerated, some of the side effects less, and make you feel overall better.
Yeah, absolutely. And as a reminder to the audience, OncoPower does have nutrition care related education videos and a registered dietitian available for questions. We did have a question come in from Sandra. Could you tell me anything about chronic lymphocytic leukemia, stage 3? I take it this is out of your purview, but I wanted to at least relay.
So it is. I can give kind of an overall arching review of CLL. So CLL, or chronic lymphocytic leukemia, is a blood cancer. So it's not a solid organ cancer like lung cancer or breast cancer or prostate cancer, or the ones that most people think of. It's a bloodstream cancer, and it's a cancer of the immune cell, one of the immune cells. It is a chronic leukemia. There's two types of leukemia. There's the acute leukemias and the chronic leukemias. CLL and CML are the two chronic leukemias. AML and ALL are the two acute leukemias. Now, the vast majority of adults, have, if they're going to get a leukemia, it's going to be one of the chronic ones. And the chronic ones, very different view as a patient and as an oncology society, where sometimes they don't require treatment. Actually, frequently they don't require treatment. You watch them because the treatment can have side effects, and a lot of the times isn't necessary when it's in the earlier stages. So CLL in the last 15 years has undergone, I would say last 5 years, has undergone a lot of advances. And there's these drugs called BTK inhibitors, which revolutionized the landscape of how we treat CLL. There's other antibody drug conjugates, we call them, where they're almost like a smart drug, like a target drug, that brings a little toxin with it. So it's almost like someone carrying a backpack with a little poison on the backpack, and they bring it right to where it needs to go. And then they open up the backpack and destroy the cell that was there. So there's been a lot going on with CLL, but it's not something that I've routinely treated for the last 10 years. But a lot of promising, effective treatments for CLL, and it's a chronic leukemia, so it's something that needs to be addressed sometimes over many years or even decades. Sometimes it's many years before it even needs treatment. So I don't know that person's situation if they're actually on treatment, or There's certain molecular types of CLL that predispose to a little bit more aggressive, of course, like a TP53 or other specific chromosomal mutations or alterations that would portend that the CLL cells might be a little bit more active. You better pay close attention to them. Or there's others that would show that the CLL cells are going to be sleepy, and that you got to watch them and make sure, but that you need to just watch without doing any intervention unless there's new symptoms related to it.
Okay. We had another question come in from John. Tyrosine kinase inhibitors, TKIs, excuse me, have led to significantly improved survival benefits for ALK-positive cancer patients. What are the available options for those who develop resistance to TKIs?
Very good question. So I'm assuming there's probably someone with an ALK fusion lung cancer. So ALK fusions occur at about 2 to 5%. That's the quoted number of lung cancers. Again, predominantly non-small cell adenocarcinomas that never smoked. That's common. And it's usually a younger person. So the typical age of lung cancer diagnosis might be in the late 60s. Is an ALK fusion lung cancer might be someone in their 40s or 50s. Sometimes even I have someone who's in their 20s with an ALK fusion. So it's something that we'll see, I would say, uncommonly, but if you treat a lot of lung cancer, you'll see it more and more often. So the ALK fusion was first picked up about 10 years ago, and the drug was crizotinib, Xalkori. And the drug has some unusual side effects, but it's pretty effective. And since then, the landscape's changed a lot. So now there's multiple ALK targeted therapies. So first was the crizotinib, then came this drug called ceritinib. And then now the drug, at least my drug of choice, is alectinib. Alectinib is Alcensa, and I'm not sure what this person that texted in the question is on or is not on any. Alectinib is very well tolerated. Meaning that if people take it and they don't get sick, they don't lose their hair, they don't throw up every day, they don't feel major impacts on their life. They can live their life as close to normally as possible, knowing what's going on. And then there's lorlatinib, brigatinib. There's a lot of ALK fusion targeted drugs. The newer ones is what we usually use first because they're the most active, like alectinib or lorlatinib or brigatinib. But if they stop working, and I think that's what the question is if they stop working, you kind of have to go away from that whole class and you have to try something a little bit different, like going back to chemo. And one other thing about these TKIs, tyrosine kinase inhibitors, and these target engines, for some reason it seems that, for example, someone with an EGFR engine, they don't do as well with the immune class. It doesn't seem to work as well as it does, say, for example, in a smoker who doesn't have one of these engines. It doesn't mean it can't work, but it just means typically won't be as effective. So the mainstay of treatment would be chemo, and it's usually chemo combination like carboplatin and pemetrexed, which is a Alimta, sometimes with a third agent, sometimes with an immune drug, or sometimes with another targeted drug called Avastin. But it's the mainstay is chemo. So if you have a targeted engine and the targeted engine is not working, treatment is not working anymore, depending on which drug you use, you might use two different ones. You might just go with one or in that class. And depending on how long you were on it before the cancer got active. For example, if you were on one of the most active ones and the cancer progressed right through it, so that 2 months, 3 months later, you saw a new spot, then you really got to quickly switch to something different. And again, different usually is chemo drugs or chemo combinations.
Okay, interesting. We had a question come through from Judy. How do you think immunotherapy has changed stage 4 lung cancer survival? I have heard something about functional cure. Is it true that people with stage 4 can be cured with immunotherapy?
Okay, very good question. I would say oncologists, once you hear stage 4 cancers, we think of treatment. We have to define treatments as either curative or palliative. Palliative just means we're focusing on improving survival rates, we're focusing on improving symptoms, but we don't think the treatment's going to be able to get rid of the cell so you can take it just for a short period of time and then you're done. So stage 4 cancers traditionally have always been described as palliative treatments. So the drugs can be active, can control the cancer, but don't necessarily cure the cancer. And 1, 2, and 3 is a different situation. So the question, though, is when you're using these effective immune treatments in, quote, the palliative stage 4 setting, do some patients get cured? The answer, I think, is yes. I don't use that word cure just because I feel like it's a loaded word. And if there's a recurrence, then there's a question of, well, you just told me I was cured. How did it come back? You told me you got rid of it all. So it's kind of more of a nuanced discussion, but no question in my mind, in my years of doing a practice predominantly focused on lung cancer over the last 10 years, that there are patients who get immune drugs and the cancer just disappears. And I follow them. Some I've followed 6 years now, and there's not even a hint of a recurrence. So would that be considered a cure? I think so. And it doesn't happen in the majority, but it definitely happens. And the more you do, the more you give these immune drugs, the more you'll see intermittent times where these patients and people with cancer can just change everything. Almost everyone, I would say, with lung cancer, especially a non-small cell lung cancer diagnosis, that doesn't have a target to go after, almost all those people should be getting immune drugs, and should be getting immune drugs as part of either the first treatment. Sometimes we'll do it alone as the first treatment. Sometimes we'll do it with chemo, but these are discussions you have to have, with your oncologist based on the unique features of your cancer. But yeah, I would say there are people with stage 4 lung cancer who the disease disappears on imaging, or is still visible on imaging, but never does anything. So you just keep monitoring it. Nothing changes. 2 years later, it looks exactly the same. And those people are feeling like they did before their cancer diagnosis. So the drugs are too new to get long-term follow-up in a lot of people, like, for example, 5-10-year follow-up in huge swaths of people. They're too new. So we don't have a lot of that information, but clearly, yes, people with lung cancer who respond to immune therapies intermittently can be very long-term responders.
Wow, that's incredible.
Yeah.
It's nice to know that there are sort of new doors opening for those patients. How important would you say getting a second opinion is during the diagnosis process? And sort of when have you, maybe you can think of a case or two where it made a real difference in the course of treatment that was given?
Yeah. So for the last 10 years, I worked at a cancer center where a lot of the patients I saw were either individuals that were seeking a second opinion, or they just came to us for their first discussion regarding treatment options. So first thing is you have to get a good flavor for your oncologist. Is it someone who's explaining things, something who's sitting down and kind of laying out, especially the categories that we talked about. What's my stage? What are the features of my cancer that would make it immune sensitive? What are the features of the cancer that would maybe make a target drug an option? So you just want to educate yourself so you understand a little bit, not that you need to know the details, but just so you understand a little bit about what are the main components of the conversation. And if your oncologist is answering those questions to your satisfaction and doing those tests, telling you why you're not getting an immune drug, telling you why you're not getting a target drug, telling you your stage and why, and you feel comfortable and confident, I'm not sure a second opinion is critical. If you feel comfortable, I don't think it is. If it's a rare situation, or you want to go on a research study, or you're not feeling like you're getting the time and the explanation that you want, then you should definitely seek a second opinion. And when you go for a second opinion, it's probably best to go to a specialist in that cancer, because you want to make your time most worthwhile. And specialists in those cancers would be like a lung cancer specialist would be usually at an academic center, a center where there's oncologists that just do lung cancer. They don't do other cancers, and they do a lot of research, and they run their PIs, which are principal investigators on clinical trials for lung cancer. So they know a lot of the research world. They're testing to see if everything that was done, and whether or not new tests could potentially need to be done. Now, the second part to your question is, has that ever been impactful when I saw a patient as a second opinion? And the answer is yes, not always, but yes. A lot of times we agree with the outside. Sorry. A lot of times we agree with the outside oncology opinion, but sometimes, yes. Like, for example, liquid biopsies, which are a little bit, we touched on it very briefly, but when you're trying to find a cancer engine, and the engines to see if there's a target option. One option is to do it based on the tissue, meaning the cell. So you did a lung biopsy and you found lung cancer cells. You run that sample for the genomic tests. So you run for the engines. Sometimes you don't have enough cells to run the test. So the specimen, because it was a needle biopsy, was exhausted. There's nothing left. And some doctors will quickly try to get another specimen. And sometimes you get another specimen, it's still inadequate. So it's not that unusual for that to happen. Maybe 20% of the time that could happen in community settings. And in that situation, frequently, especially in stage 4, it's good to get a liquid biopsy, which is a blood sample. And in the blood sample, you're looking for the same thing. You're looking for the tweaked DNA, the mutations that formed in the cancer cell. But in the blood biopsy, you're looking for the broken down DNA. We call it cell-free DNA or circulating tumor DNA, ctDNA, which is, think of a cancer cell as a little balloon. And they die off like any other cell. And when they die off, the components of the cell kind of float around the bloodstream as your body clears it out, figures out what to use, what to waste, and your body's just doing this constantly. And some of the DNA that's floating around, that's cancer DNA, they can look for those engines, the same engines you look if you looked in the cancer sample. And you could imagine now you're looking for it in an ocean of the bloodstream. So the likelihood of you finding it is much lower than when you're going right to the source, the actual cell that you biopsy. But the technology has advanced so much over the last few years that they're able to detect the needle in the haystack of the cell DNA. So especially when cells have spread and you find, like a lung cancer cell in the bone or in the liver, the chances of you finding the DNA in the blood go up and up and up and up. As opposed to if you had a little, like 1 centimeter nodule in the lung, the chances you find the DNA in the blood is very low because there's not a lot of cells and there's not a lot of spreading going on. But when it starts advancing more, and most cancers are picked up, unfortunately, lung cancer is at 3 or 4 stages when they're more advanced. The tests in the blood can actually be commonly picking up those mutations or engines, and checking for them will sometimes help you pick up one of these target engines. And if, say, a local doctor just didn't have the technology or just didn't do that test because they ran it on the tissue, didn't have an answer, and then you run it on the blood, you find an answer. And then you find a mutation like we just talked about with that previous question about the ALK. You find an ALK fusion. Now you got a whole class of drugs that can be very active to fight that cancer. And I've seen that before where patients will come in for a second opinion. They've done a couple of biopsies, haven't gotten an answer. We run a liquid biopsy, we find a fusion or a mutation that we can target. And then that changes a lot of the course. It changes the treatment options. It changes the prognosis. It changes the side effect profile because you're given different treatments that may be much better tolerated.
Wow. We had another question come through from Natalie. It's a little adjacent to lung cancer, but I'll see if you want to take a stab at it. My husband received his final diagnosis of stage 4 esophageal cancer. It has spread to his liver, colon, lymph nodes, and bones, and a few spots on his lungs. The oncologist told him that there was one kind of chemo he could do and warned him that it would be harsh. It would only give him a few extra months. He's sleeping most of the time now. Are there any clinical trials that you think are relevant to his case?
Okay, so sorry to hear about that, by the way. I'm sure that's a huge amount of stress on your shoulders, just having to handle that as a caregiver and someone you love. That being said, esophageal cancers have undergone also some recent changes. Esophageal, GE junction, gastric, it's all kind of the same region of the body. The lower esophagus and the stomach is interconnected. So there's two approaches besides chemo that we need to think about. One is the immune drugs, and there's a marker test that we do called a PD-L1 or a CPS score. It's a number we get. And that determines whether or not you want to add the immune drug right up front to the chemo. And a lot of this depends on, how functional someone is. If they're sleeping and resting a lot, you have to be careful with the drugs because you could hurt someone and cause more problems related to the side effects of your treatment. So you just got to be really cautious of that. But there is an immune marker test you want to check. And then there's a specific engine called HER2, H-E-R, then the number 2. And HER2 is seen in lower esophagus, stomach, GE junction, this region, about 20% of the time. More GE junction in stomach, but sometimes depending on where the cancer started in the lower esophagus, you want to test for it. And if there's a HER2 overexpression, we call it, but it's kind of like a mutation, a little slightly different than a mutation, then you would use a targeted drug. It also goes in the vein, but you use that as a targeted drug, sometimes with chemo, sometimes by itself, depending on the situation. But that would help target the cancer more effectively and with less side effects than sometimes chemotherapy would have. And there's actually a second line now targeted HER2 agent. So HER2, that engine, there's 2 separate drugs now that have been approved to target that HER2 engine in GE junction, distal esophagus, stomach cancer. So you want to make sure that those have been explored. The HER2 engine, you want to make sure that the PD-L1, which is in that case a CPS score, C as in cat, P as in Paul, S as in Sam, and it gives a number anywhere from 0 to 100. Although CPS scores, it's broken down on like 1 to 5, 5 to 10, greater than 10. But those things need to be explored just so that you make sure that you're laying out all the options. But when the cancer spreads like that in the liver and other organs, and someone's very weak, it's a really tough situation. It's a really tough situation knowing what's, based on someone's age and functional status, what's the best approach. So this is something you really got to tailor with your local oncologist.
Excellent. Thank you for filling that in. Are there any sort of, I don't see any more questions coming through. Oh, wait a minute. We have one last question. Recently, I've read online that immunotherapy works better in those who are not on antibiotics. Interesting. Would you recommend patients on immunotherapy to try to work prebiotics into their diet?
Okay, so I'm not aware. So immune therapy stimulates your immune system to go after cancer cells. So there are ways to reverse the effects or reverse the side effects from the immune drug, and that's steroids. So if someone has a side effect from an immune drug, we give steroids and that counteracts the side effect. So if someone gets an immune drug, it gets diarrhea, for example, which is an intestinal side effect. You give steroids and that usually stops the diarrhea. And then you taper it over, usually I do over a 6-week period. Antibiotics, which kill bacteria when someone has an infection. I'm not aware of antibiotics as a treatment that would negate the effects or the benefits of the immune drugs. So it's a separate issue in my mind. Now, the gut flora or the gut microbiome, which is the bacteria in the gut that are naturally present, that antibiotics sometimes destroy because that's what antibiotics do. And that's one of the negative effects of antibiotics is if you take too many of them or take them unnecessarily, or you get them frequently, sometimes it affects your GI tract flora, the bacteria that naturally present there. That might, who knows, have some effects on immune treatments. I don't know that. That's a very debatable and an area of intense interest. But right now, I would say standard, if someone needs an antibiotic, you would give them an antibiotic, and we don't worry that that would make the immune drugs less or more effective. Steroids, which are totally different than antibiotics, will I wouldn't say negate the benefits, but will deal with the side effects, will calm your immune system down and deal with the side effects that the immune drug sometimes causes for people. So for example, sometimes people get a lot of diarrhea. Sometimes people get a terrible skin rash. Sometimes the immune system wreaks havoc on your glandular system, like your endocrine system, which could cause the thyroid gland to be affected. Sometimes it could cause the liver or the lungs to get inflamed. But these are all rare side effects and treatable. And sometimes when these side effects happen, actually, it's just telling you that the drug is effective. And the people who get these side effects have actually a higher likelihood of a response to the immune drug than people who have none. Again, it doesn't mean just because you have a side effect, it's going to work. And if you don't, it's not going to work. It doesn't mean that at all. But the immune drug side effects are dealt with steroids. And I'm not aware of antibiotics negatively or positively affecting the immune drug benefits.
Okay. Well, Dr. Gershenhorn, thank you so much for your time and expertise. This was really informative today.
My pleasure. My pleasure.
And that last question teed us up pretty nicely. We are going to have a session on clinical nutrition coming up next. It'll be in the next week. We will be finalizing that date and announcing it for everyone. And we just want to thank everyone again for participating today. And, any sort of additional questions or support needed, please come join us on OncoPower. Thank you.
Thanks, guys.